everyone, my name is Debbie. I am one of the clinical educators here at Cleveland Medical Center at University Hospitals. We are going to be discussing today how to get cardiac output from your SWAN as well as thermodilution. The first thing that you're going to need for your patient is a SWAN, which is usually in the right IJ. You're also going to be wanting this lovely number here, which tells you what computation constant to program into your Phillips monitor. Let's discuss a little bit of the lines. Your white line here is your VIP line, that is for medications. Your blue line here can be transduced to get your CVP. It goes right into your right atrium. Your yellow line here goes right into your pulmonary artery. It gives you pulmonary artery pressures. You can also get your venous gas, mixed venous gas, from this pulmonary artery. And your red line here, which should always be locked without air in the syringe, will get your pulmonary artery wedge pressures. So that's the basic components of your SWAN. Every SWAN should have those 4 lines. Sometimes you'll have extra lines associated with that connects to monitors and things like that. You will also need a transducer. I have a lovely transducer here that is a 3-way. It goes right to your pulmonary artery as well as your CVP line. And you can adjust your stopcocks to what you want to measure. You're also going up here, getting to your cardiac output box, and making sure that you have a pulmonary artery pressure on your Phillips monitor. The first thing you're going to do is make sure that you have 300 millimeters of mercury in your bag, which I do not. So I'll increase that. Get my green line here. Beautiful. There we go, 300. What you're going to want to do for your patient also when you are reading your pulmonary artery pressures is going to be putting your patient down as low as they can possibly go. So what I'm going to do is just lower the head of my patient. To get the pulmonary artery pressure. Right now, my transducer is open to both lines, your CVP as well as your PAP. So you can get both pressures on your monitor. If I just want my CVP, I turn it off to the PA line to get your CVP only. If you're grabbing a mixed venous, you put it off to the line, take this off, you're going to grab your mixed venous right from there. I'm going to leave this open to both of the lines so you can see both of your lines open here. So my patient is down. She is extubated. What I'm going to do over here is see my respiratory waveform as well as my PA waveform. I'm going to be measuring my PA pressure at the end expiration, which for my patient who is non-intubated is in the peak just before it goes down into the valley. When he is taking a deep breath in, the waveform goes down. If my patient is intubated, I'm going to be measuring at the valley right here, just before my patient goes up. Reverse for intubated as well as non-intubated. Think of ventilator, valley, patient, peak. My patient up here on the peak, I go up to the pulmonary artery pressure up here. Let me just freeze that. Wave here. Right here is I'm going to be taking the average of here and here. 28/15 is pretty accurate for my pulmonary artery pressure. I'll unfreeze that wave so I can read again. When I do want to get a CVP, I'm going to go down here and open my lines, close the line to my pulmonary artery pressure, keep the lines open to my CVP, make sure my transducer is at the 4th intercostal space, mid-axillary, which is about right there. For training purposes, I'm just going to hold this up here. And then you can just change this waveform to a CVP. You're going to be measuring your CVP. This isn't a very good waveform. It's pretty dampened, so I'm going to optimize that scale so I can make sure that I get those waveforms. You're also going to be measuring your CVP at the end expiration on your C wave. So the end expiration right here is about right here. We freeze that wave, it's about right there. So I know that my CVP is around 9 or 10. The numbers are over here. Unfreeze those waves. Now that's how I get my CVP. I also need to get a wedge pressure. We're going to go to wedge. We'll first change this to a PAP again by just changing the label. I like to optimize my lines just because it's easier to see all of your waveforms. When I do wedge, I am going to be taking my red line here, unscrewing it from the cap, putting 1.5 cc's of air into here, hooking it back up to my line and opening it up. If you see a straight line, it is open, just like with your stopcocks. You go over to here to your wedge. You see my pulmonary artery pressure. I'm going to be pushing air in slowly and continually watching my waveform. That is your wedge right there. Now, I'm going to edit wedge. Now, you can take the air out of your line now. Make sure it is all the way out. Lock. This lock right here. Unscrew and take all of the air out of your syringe before you reattach it to your line here. That is how you get the wedge. Your patient should also be flat. When you do edit your wedge, you're going to be measuring at end expiration again, which for my patient is at the peak. This is your end expiration up here. So I'm just going to be moving my wedge over just a little bit, right before it goes down. Then I'm going to be moving my cursor. This is your vertical cursor. Now your horizontal cursor is here, and it comes at almost that diacritic notch right there. It's basically in between the top and the bottom of your waveform. But it's right at that diacritic notch right there, if you can see that diacritic notch. So your wedge is about 9. Again, end expiration for patient is at the peak. End expiration for your patient who is intubated is at the valley. I will store my wedge. When you X out of here, you can do some hemocalcs to grab all of your numbers. The wedge pressure here we'll put as 9 and enter. Our CVP was around 9, but you can change that if you need to 9 or 10. We always print out our waveforms just to make sure. Then we're going to do a perform calc, and it gives you all of your numbers. Now notice, why don't I have SVR, CI? It's because I didn't put a height and weight in for my patient. If you have a patient who is not admitted, or the height and weight is not entered in there, you're not going to get a cardiac index as well as SVR, which you definitely need for your patients. So you have to put these numbers in to actually get numbers for your patient. And we're going to just perform calc again. And that gives you your cardiac index. Now your physician wants cardiac output with thermodilution. You're going to need a thermodilution set up with either normal saline or D5. Just note that if you use D5, you are injecting solution that has sugar in it from your patient. I'm using normal saline here, 500 bag. It's also important to calculate the amount of injectate that you inject into your patient. I usually like to inject 3 to 5 times, so that's 30 to 50. You're always injecting 10 cc's. You will need this setup to do anything. You need a 500 bag of saline or D5, as well as your syringe here, and it all comes in a kit. Where are you going to be injecting? You're going to be injecting into your right atrium, which is your CVP port. If you look here, my CVP port is blue. So I'm going to be injecting at the closest point possible. If this comes off, it does not, I'll be injecting right into here. So you take this off, this cap off. You put this cap on, screw it in. Now, when you are taking saline, you're taking room temperature saline, putting it into the right atrium of your patient. The monitor is measuring the injectate at room temperature. Your core temperature is about 20 degrees higher than room temperature. It's going to be measuring the injectate as it goes through your heart, hence measuring your cardiac output. So, you also need a thermistor. This is your thermistor. It connects right into here. Please don't try to connect it here because it is very sensitive. It also comes out very easily. So you really have to monitor that and make sure that that is on your patient as it goes into your patient. What you're going to be doing is taking 10 cc's of saline from your line here. So I'm going to be turning everything off to your patient because I don't want to be taking blood from my patient. I want to be taking it from this line here. So I turn this off to this line, pull your 10 cc's of saline. I have a little bit of air in that, which is not a good thing. Like I said, make sure that this is connected here. Then you are going to be going into your patient. So I'm going to be turning it off to this line here. Turn my stopcock off here. And I'm going to be going into my patient, which I turn my stopcock off to here as well. So therefore, the saline is going right from here into your patient's CVP line. When you do thermodilution, what you're going to be checking is your cardiac output, and you're going to be start CO. When it does say inject now, you're going to be taking your syringe and going as fast as you can. Here we go. Probably over about 3 seconds. Then you are going to be turning this off to your patient while it measures your CO. You won't have to push that demo inject. You're going to be getting that nice curve that we talked about, that C curve. If you do get kind of a diacritic notch in there, then that is a wrong injectate technique. If you do get a high curve like this or a tall curve, that means that you have a high cardiac output, and if it is kind of dampened, it's probably a low cardiac output. You are ready for new measurement, so what you're going to be doing is basically grabbing 2 or 3, 4, 5 samples here. So I'm going to be pulling from my line again, pulling 10 cc's from my line now that everything is off, turning my stopcock off. So it's open here, and going into my patient. If you have to push start CO again, that's fine. Okay, it says inject now, end expiration, inject now. And then it tells you to get ready for a new measurement, which you just take your 10 cc's again from your patient and wait until it says inject now. Ready for a new measurement. I'm going to be turning this off to my line. End expiration. Start CO, wait for my patient's end expiration, and inject. Fast and consistent, making sure this always is there. And then I'm going to be turning this off and taking the thermistor out. We're done with our measurements, so I'm going to disconnect this from the hub here. You're going to put sterile to connect these. Sterile. You'll also put a sterile one on here. I dropped mine on the floor. I'm done with my cardiac output, so I'll look at my numbers up here. Make sure to put your patient back upright too. Now I have a cardiac output of 3.43, 13.7, and 5.2. I don't like those numbers. They are not very consistent at all. So definitely I would want to do at least one more to make sure that I got what I needed. Anything with a question mark, you're definitely going to question that one and see if it's a good curve as well as consistent with the others. I'm going to get rid of that 13.7 because I know my patient doesn't have a cardiac output of 13.7. How do I do that? I just push the waveform there and it turns it red. And say that I like that 3.43. It has a good curve. Let's get rid of that one too. All you do is push that one. You're going to save CO. Your CO is 5.12, your cardiac index is 2.96. You're going to print record, and then you're going to record. And then it will print out your cardiac output that you can save and give to your physicians. If they do want to see those waveforms and things, you also can give those to your physician as well. Mine has an X on it because it's a demo patient. And I rejected those. And that's how you get cardiac output for your patient. Record it. Make sure you X out of there and make sure all of your lines are still open to get your CVP with your blue line and your PAP with your yellow line. Transducer is wonderful that it has open and open, so you can just turn your stopcock to get your pulmonary artery pressure. That's your yellow line, or keep it open to your CVP at all times. Thanks for watching. I hope that you can do this in practice. Just slow down, do it right, and get your numbers. Thanks for watching.